Thank you. So, hello, Club Med virtual members. I would like to give a warm welcome to our guest speaker, Dr. Chris Reilly. Dr. Reilly is an emergency medicine resident at HCA USF Brandon Regional Hospital in the Tampa Bay area, so he's nice and warm.
Yes.
We are incredibly grateful for this shadowing opportunity and hope to learn a lot today. As a reminder to our Club Med virtual members, if you'd like to have your camera on, we highly encourage it as long as you stay on mute while Dr. Reilly is talking. There will be a survey given at the end of the session for Wayne State University students to obtain shadow and attendance hours. To reiterate, only WSU students present today can receive hours. We are also recording this session, so to anyone watching from YouTube, hello and thank you for watching. And I'm going to turn the session over to you, Dr. Reilly, and you can take it over from here.
Sure. I have a quick question though. How do I screen share? I've never done that on Zoom. So, because I have a PowerPoint that I just want to go, I'm going to run through a quick case for you guys.
So on the bottom of your screen, there should be a green button that says.
Yep. Boom.
Yep.
Got it. Awesome.
And I'll make sure to read out any questions posted in the chat, but if you guys want, you can also raise your hand to indicate that you want to answer anything or ask a question.
All right. There it is. Okay. So I'm Chris Reilly again. I'm a first-year resident at Brandon Regional Hospital. It's a hospital right outside of Tampa, and it's associated with USF Morsani School of Medicine. Go Bulls. So, guys, today I'm going to just run you through a pretty straightforward case, something we see a lot of in the emergency department. And the thing with emergency medicine is you see a little bit of everything. And you see, the crashing asthmatic, you see trauma, you see, people or pregnant people giving birth. You do all kinds of crazy stuff. But this is a pretty straightforward one. Again, I don't know how much anatomy and physiology you guys are familiar with, but this is a case, actually, one of my good mentors and close attending friend at my program, Dr. Martin Kim. He does some lectures with the USF med students, and this is one of the sim cases that he wrote up and he let me borrow. So shout out Dr. Kim. So let's start with, go in your head and try to just imagine this person, right? So we have a 74-year-old male with a history of emphysema. Emphysema is a disease caused by chronic, destruction of the lungs, primarily due to cigarette smoking. It can be caused by a lot of other things too, but that's primarily the number one cause. He's got this history of emphysema, and he's brought into the ED, the emergency department, via EMS, Emergency Medical Services, for SOB, shortness of breath. It's not the other SOB. We're starting to transition to DIB now, difficulty in breathing, because SOB, sounds a little bit too much. Okay. So these are vital signs, guys. So HR is heart rate. He's got a heart rate of 118 beats per minute. Normal heart rate is between 60 and 100 beats per minute. So his heart rate's too fast, right? So I already know something is not okay right off the bat. Blood pressure, 170 over 80. Normally that's about 120 over 70, 120 over 80. So again, it's too high. So something's off here. Respiratory rate, 28 per minute. Normally we're like 12 resting. So he is working hard to breathe. He's got a very fast respiratory rate. So I hope you guys are getting like a picture of this person coming into the emergency department in your mind. Temperature, 100.8. That's fever. Over 100.5 is a fever. He's got an oxygen saturation of 86. Anything over 94 is normal. So again, just every vital sign is off. So this guy's sick. This is an EKG. I don't expect you guys to know what's going on, but this is a P wave. You got a Q, R, S wave, and a T wave. And these are pretty close together, which tells me his heart rate is fast, which you already know his heart rate. I don't see any signs of heart attack or anything other bad. It's just a typical COPD reading, as well as some tachycardia or fast heart rate. Okay. Okay, VBGs. So when we do blood work, right? Sometimes we get VBGs. We get these on emphysema patients, COPD patients, chronic obstructive pulmonary disorders. And two of those are emphysema and bronchitis, chronic bronchitis. So those are the two different types of COPDs. And for all of those patients, and especially asthmatic patients, when they come in too, working hard of breathing, they're having like an exacerbation of their asthma. We look at a VBG, and the VBG is going to tell us the pH of their blood. pH of someone's normal blood is 7.35 to 7.45. So we all know humans have to live in that sweet spot, right? Because if you get too low on the pH scale, you're acidotic, not good at all. If you get too high, you're going to be alkalotic. That's why we learned this stuff in Gen Chem. As much as it sucked, I hated Gen Chem, but we have to learn it just to understand these basic concepts, right? So there's too many H ions in the blood, and that could be caused by a bunch of different things. A huge cause is lactic acid in the human body. So let's go to the next one. PCO2. This is the amount of carbon dioxide in the blood. So we have oxygen, which is carried by hemoglobin in our red cells through the blood. That oxygen is dropped off to different tissues in the body to supply oxygen and oxidative phosphorylation to produce ATP for our cells, which we know from cell biology and biochem. And again, these are concepts that everything in medicine builds on each other. And it's so important to know these basic concepts of anatomy and physiology. So the PCO2 normally is 35 to 45. This one's 70. So that's telling you he's retaining CO2. He's not getting that CO2 out of his lungs. And COPD in general is a disease that, if you think about it, like a normal lung is elastic. So you breathe in and then you get that elastic snapback, which shoots air out of the lungs. If you have COPD, think about it like you're breathing into a trash bag or, like a plastic bag, right? It's really easy to blow it up, but it's so hard for that bag to deflate. And that's basically what COPD is. And that causes your retention of carbon dioxide. So this guy's carbon dioxide is pretty high, right? The upper limit of normal is 45 and he's at 70. So significantly elevated. And we have a lactic acid of 2.1. Again, that's a little high. I think the upper limit of normal is 1.9 to 2. So we know it's a little bit high. We know that something's going on here. Lactic acidosis can be caused by many different things. A big one's infection. So we see all these lab abnormalities. We see he's got fever. What are we going to do? These are the rest of the labs. Troponin I, don't worry about that. That's for cardiac tissue. BMP is a basic metabolic panel. Sodium's fine, potassium's fine, CO2. That's actually a bicarb, which is actually normal. It's different from PCO2. BUN is how much urea is in his blood, 28. That's okay. Creatinine 1.1, that's kidney function. And glucose 140, a little high. This is a normal X-ray, okay? I just want you guys to see what normal is before I show you abnormal. So as you can see very nicely inside this lung right here. It's very clear. You have clear markings. There's no like whiteouts or anything strange in here. Maybe this is a little bit too tall. Could be like an emphysematous lung. I'm not sure. But this is what I Googled. I said normal chest X-ray. This is the first one so I picked it. And then this is actually his chest X-ray when you get it. Okay, so it doesn't look too good, right? So compared to the last one, this is pretty clear, right? I mean, it's a little bit hazy, but that's just from vascular markings. Maybe this is an older person. This one for sure, you see this is hazy right here. So this guy has COPD or emphysema, and he's got a lower lobe pneumonia, okay? Let's talk about his history a little bit. The patient was recently discharged from the ED, the emergency department, 2 days ago for a COPD exacerbation, which means that his COPD got worse. He was short of breath. He needed intervention in the ER. He states he was becoming increasingly short of breath with exertion and in cold weather. He's normally able to do yard work and move freely. However, he's been unable to do either. He's unable to sleep flat on his bed and therefore sleeps in a chair. He's been coughing up like yellow phlegm. He's been really tired. He gained about 3 pounds in the last 2 to 3 days, actually. But he denies fever. And again, going back to this history, this is a little bit more complex. But the heart, as you can see here, is okay. It's kind of smaller. It takes up about 1/3 of the chest X-ray. Then you see this heart, and it's big. It's globular. This is somebody who could be a COPD with heart failure, which you have backing up blood, and you get to retain fluid in the lower extremities. So that's no bueno. He's a smoker, obviously, and physical exam. You walk in the room, he's distressed. He's sitting up in bed. He looks a little bit blue too. That's how you can tell he's got decreased oxygen. And the rest of the exam is, pretty unremarkable. His labs, I showed you earlier, his chest X-ray is great. Now, this guy, what you want to do is COPD exacerbations happen all the time, right? When you have a disease that is chronic, AKA it's something you have at baseline for a long time. When you have flare-ups of those diseases, that means something is going on inside the body. The most common cause of exacerbations of, let's say, congestive heart failure or COPD or asthma or whatever, the most common cause of these flares are actually infection. So if somebody comes in with a history of COPD or emphysema or whatever, and you see all of a sudden that they're really working hard to breathe, you got to think infection. I mean, you don't even need to look at vital signs yet. You just see, okay, this guy's history of COPD, he's coming in, he's working hard to breathe. Something put him into his COPD exacerbation. So in the ER, our biggest mantra is IV O2 monitor, right? And glucose, which is, that's depending on who you are. But IV, got to get IV access just in case this guy starts crashing. We got to give him medications to, help him stay alive. O2 is put him on oxygen. Man, this guy's oxygen saturation was what? 86%. He could be living at a low oxygen saturation because he does have COPD. That's typically like 92. So something's going on here. So we got to we have something called a nasal cannula. I don't know if you guys have ever seen it, but it's a piece of tubing that goes in the nose and then over the ears and down here, and it connects to oxygen. And we typically put that about 2 to 4 liters per minute of oxygen pouring into the nose just to try to get that oxygen saturation up a little bit. So IV O2 and then monitor. We typically put electric leads on the person's chest and attach it to the monitor just to, see their cardiac function and see the electricity of the heart, aka the EKG, but in real time, right, on the monitor. So IV O2 monitor, blood glucose, just to make sure it's not decreased, or hypoglycemia, if you guys have heard that word. So oxygen supplementation, you want to put them on nasal cannula, that thing I just talked to you about, 2 to 3 liters per minute. The biggest mainstay treatment for COPD exacerbations is Duoneb. Duoneb is a medication that we give in the emergency department, and pulmonologists give it. Everybody can give it technically, but it's a combination of a drug called albuterol and ipratropium. So both of these medications in combination help bronchodilate, which is dilating the bronchus or the bronchi or the bronchioles. So what it does is it helps relax the smooth muscle in your lungs to let as much air in as possible. So it bronchodilates. So you're getting air in. So that's one part of COPD. But the worst part is that you can't get air out, right? So ipratropium actually helps with that. Another thing we're going to do is we're going to order blood cultures. The guy's got pneumonia, right? So he's got an infection in his lungs. Look at this thing. So automatically we're starting antibiotics broad spectrum antibiotics covering for a lot of different nasty bugs. Because especially someone who's got a chronic problem like COPD and was just in the hospital, that means he's prone to a lot of nasty bacterial infections. So we got to do broad spectrum antibiotics. We got to get blood cultures, make sure that he's not septic. He doesn't have those bacteria in his blood. And if he does, the cultures will actually grow what bacteria type he has. So then, infectious disease specialists or the internal medicine docs, after you admit this patient, they take care of that and they figure out what's the best antibiotic for this person. But in the emergency department, we just throw the broad spectrum antibiotics at them because we don't really know too much about this patient. We do the best we can. And last thing is steroids. So not the baseball kind of steroids, but steroids used to decrease inflammation. Okay. So super important. Again, this COPD exacerbation is chronic inflammation in the lungs, chronic scarring of the lungs. The steroids help a lot with these patients, sometimes too much. My grandmother, she actually just passed away this past year, but she was a longtime smoker. And this lady would pop prednisone or steroids like crazy. And that's dangerous. I would have to tell her, stop doing this. This is going to kill you, These steroids, they over time, if you take too much, it's always a bad thing, right? Everything in moderation. You do too much of one thing, it's really bad for you. But in this case, you definitely need it to help with, decrease this inflammation. So those are the steroids, and then IV fluids. You can just start 30 milliliters per kilogram. In medicine, everything is in the metric system. It's not in the US system. So everything's by kilogram. All medications are milliliters per kilogram, or milligrams per kilogram, or micrograms per kilogram. So there's a lot of stoichiometry, if you remember that too, from Gen Chem. So this guy, you need to realize that he's got impending respiratory failure, right? This guy's crashing. He's not doing well. He's I can't breathe. He's talking to you like that, right? When you have somebody who's failing to speak in full clear sentences like that, gasping for air, this guy's crashing, and he could, crash any second. So you need to get advanced airway equipment to the bedside because you may need to intubate this guy, which we do quite often in the emergency department. I would say, anesthesia is like, oh, we're the masters of the airway. And, I'd say in the emergency department, we're pretty good at it, and we're good at crashing airways. We're good at difficult airways. If somebody's like throwing up blood or something, like we have to like suction out all of that and put in a tube really quick just to make sure that we can protect their airway and get that oxygen to the lungs and the rest of the body. So this guy, it's really bad to intubate COPD and asthmatics because you don't want to increase the pressure, the back pressure from, as I said before, like the garbage bag. It's like a garbage bag. It expands, but it's really hard to bring down. So you don't want air trapping. There's all sorts of reasons why we don't typically like to intubate. So there's this thing called BiPAP, and bilevel positive airway pressure is what it stands for. So it's this mask that they put on the person's face, and they basically have these super tight elastic bands on the back of their head, and it's basically stuck to their face, and it's super uncomfortable for the patient. But what it does is it's got positive airway pressure, so it blows air in and keeps the alveoli open. Alveoli are the lung oxygen exchanging center for the lungs. So you do oxygen and CO2 exchange at the alveoli. So what this positive pressure does, it goes down the airway, expands, opens the alveoli. And then at the same time, it keeps them open with the other pressure, which again, this is like advanced airway physiology or lung physiology that I don't really want to get into because then we'll be here all day. But that's typically the treatment for COPD exacerbations. It's actually a really good treatment. It works really well because the respiratory status could continue to deteriorate, right? And then you can go up from there and put oxygen way up, all that stuff. And let's say the guy's poorly compliant on BiPAP, like he keeps trying to remove the mask and he's just not getting enough air. You got to intubate this guy. It stinks, but that's the only option because he's not going to get oxygen and he's going to die if you don't intubate him. So you have to push some meds to paralyze him and sedate him. Then you switch up the vent settings, and then you intubate. So you go through the vocal cords with a tube, basically, which I'm sure you've all heard about from the news and all the COVID cases and everything. And all these people on ventilators. That's typically what we do for COPD if it gets to the point where BiPAP isn't helping, right? COPD patients require high minute ventilation. So we typically, there's a whole equation. Again, like I'm not going to get too far into it, but we want to avoid over distending the lungs, because then you could get like a pneumothorax where the lung basically collapses and then you're in a whole nother world of hurt and you got to throw a chest tube in and all this other crazy stuff. So this could turn into a disaster very quickly if you don't know basic anatomy and physiology. Like I promise, guys, if you're going to be doctors or PAs, NPs, whatever, if you're going to be doctors, you need to have a solid understanding of anatomy and physiology, because it just keeps building, right? First year is anatomy and phys, second year is pharm, all this other stuff. And then pathophysiology, which is like physiology is how the body normally works on a microscopic level. And then pathophysiology is what goes wrong in disease processes based on physiology. So again, this is super important to know. So this person's going to the ICU pretty much. But you did a good job because you're ER docs and you're confident and you know your anatomy and physiology, and you guys saved the person. Now they're going to MICU and, they get medical ICU and they get dispoed and they get discharged a couple days later and go back to their family and their grandkids. And that was because of you guys. So give yourselves a round of applause. Good job. So anyway, that was my quick case. Does anybody have any questions about the case in general? I know I went pretty quickly, but again, this is a pretty advanced topic, and I didn't really want to go too in depth.
Someone actually asked in the chat.
Sure.
About draining the fluid.
Draining the fluid where? Did they mean like in the lung?
Yeah, you said there was fluid on the lungs that we saw in the X-ray, and he gained like 3 or 4 pounds. So
sorry. So that I was talking. Okay, that's like there's a heart failure exacerbation in this COPD case, but I didn't want to confuse anybody. I shouldn't have even said that. So typically, what COPD does, right, is over time your lungs are scarred. Your right side of your heart is constantly enlarging because of the backup of blood, because blood is it's called core pulmonale. If you guys want to look it up, I'll type it here. It's a pretty advanced topic in pathophysiology, but in lung pathophysiology. But core pulmonale, what it basically is its right side of your heart is failing. So that means the blood is backing up into the IVC and the SVC. So you're going to see blood actually backing up all the way down to the feet. And this person actually had edema in their feet, which is swelling. So sometimes you see old people with swelling in their legs, and you could actually press on their leg and leave an imprint of your thumb. And that's called pitting edema. And that is a sign of heart failure. And that is the retaining of fluid. You can also have fluid being retained in your lungs, but that's typically for left-sided heart failure. Because basic anatomy and physiology, we know, right? The heart has 4 chambers, right? So you have the right ventricle, which connects to the inferior vena cava, which is from the rest of the body, and the superior vena cava, which is from the upper part of the body. Goes to the right ventricle. Right ventricle feeds, or right atrium. Right atrium feeds to the right ventricle. Right ventricle sends that non-oxygenated blood to the lungs. The lungs then oxygenate that blood. They send that blood to the left atrium. The left atrium sends to the left ventricle, and the left ventricle shoots oxygenated blood through your aorta to the rest of the body. So that's like a super simplified version of the cardiopulmonary system.
Okay.
And so if you have left heart failure, that means the pump on the left isn't working to send blood to the rest of the body. So what that means is that the left heart then has all this blood that's backing up because it's weak and it can't pump out blood. So the left ventricle blood backs up into the left atrium, and then that left atrium then backs up into the lungs, which causes fluid in the lungs.
Okay.
So COPD, typically you wouldn't see fluid in the lungs. You would see it in the periphery and in the liver. Sometimes you get ascites, which is like fluid in the belly, but that's typical for alcoholics or people with cirrhosis as well. But so you don't see fluid on the lungs. What I showed you on the X-ray was, I'll bring it up again. So this X-ray right here, let me screen share again. So this X-ray, what it's showing, right, is this right here. And this is an infection. This is basically pus filling up the airways, called pneumonia. And pneumonia is a very severe thing. And again, this infection is what made this person go into an exacerbation of COPD. Okay. And this is the lower lobe of the lung. The right lung has 3 lobes: the upper, the middle, and then the lower. And this lower lobe is completely filled with pus. And that's, something that it requires admission to the hospital, IV antibiotics. And in this case, the guy had to get intubated. We sent him to the ICU. On the left side, there's an upper lung and a lower lobe. And that's about it. So the left lung has 2 lobes, right lung has 3. So that's a little bit more anatomy and physiology for you guys.
Thank you for the clarification.
Yeah, of course. And again, don't get overwhelmed by this stuff, guys. Like it took me like 10 years to like really truly master all this stuff. So it takes a very long time. So don't be discouraged. Who has a question?
So Anne has their hand raised.
Sure. What do you got, Anne?
Well, this isn't a very medical question, but I was just wondering, as an ER doctor, has there been any times where you get patients who aren't insured or something, and then so does that change the care you give them, or like
Absolutely
does that change
not.
anything?
No. Emergency medicine is cool because we don't worry about insurance. We don't worry about any of that stuff. We order the tests that are necessary for the patient, right? And that's what makes the emergency departments in America are getting more and more utilized because people are impatient, and you wouldn't believe the type of people that show up to the emergency department with things that are not emergencies at all. Just general things. Some people come in like demanding a CAT scan because they know they're going to get it that day. And we go, no, there's no indication to give you a CAT scan. You need to leave. Those people suck and we don't want them. So the people that we treat are anybody who's sick, anybody who has a legit medical complaint. We will still treat them if it's a super minor complaint. It's just a waste of resources, and it's a waste of time, and it's a waste of healthcare spending in America, because our healthcare spending continues to skyrocket. But the people that truly need the medical intervention, it doesn't matter who you are. You could be a homeless man on the street. We have actually a few regulars in our emergency department that come in regularly with a complaint because they get a room and maybe they get to stay for a little while and get a sandwich and that kind of stuff. That happens pretty often. It depends where you practice too, because there's county hospitals, which are typically inner city hospitals. You have rural hospitals, which are going to be, underserved areas as well, actually. One of our freestanding emergency departments that we work at is in a pretty rural area. And some of these people haven't seen a primary care doctor in like 9 years. And they come in and they're like super sick. And they just don't understand that. But there's county programs, there's community hospitals, which is like a run of the mill regular hospital, right? And then there's academic hospitals, like let's say Tampa General, which is USF, like Cornell or New York Presbyterian, Mount Sinai in New York, like all those kind of hospitals.
I'm sorry, one more thing. If you work at a Christian hospital, does that change anything? Because I've heard that like if there's pregnant women or they need some kind of like emergency, like abortion or something like that, like then no.
So there is no emergent cause for needing an abortion, except if it's an ectopic pregnancy, right?
Yeah.
So you can always go to an OBGYN or a clinic to do that. No one comes to the emergency department for that. We get ectopics all the time, and that's not a viable pregnancy. So it's technically not abortion, right? So, I as a med student, I rotated at a Christian hospital, St. Joseph's in Paterson, New Jersey. Fantastic emergency department. Some of the most empathetic doctors I've ever worked with, and some of the best doctors I've ever worked with. And they, it doesn't matter. People come in constantly for ectopics or even pregnancy routine care. So that doesn't really stop us either.
Cool. Thanks. Thank you.
Yeah, of course.
So I know, Eric, you had your hand up first.
Mr. Ramirez.
Yeah. So I just got a question about like what specifically do you guys study, like medicine and emergency medicine doctors? Like, is it like a specific route for certain positions, or is it like you guys learn the body overall, or how does that work?
So, med school is the same. Everybody takes all the same classes. Third year is all core rotations. So you'll do internal medicine, you'll do family medicine, you'll do, you'll do surgery, you'll do OBGYN, and let's just throw a couple others in there. And you could, I guess, do whatever kind of rotations you want. One of mine was emergency medicine. But my first exposure to EM was actually as a scribe in the emergency department. And I loved it, but I kept an open mind my third year and tried to enjoy every rotation I was on and try to envision myself being in whatever specialty I was rotating through. And I think that set me up beautifully for doing my EM rotation, being like, whoa, this is definitely what I want to do. In terms of residency, first year you do a lot of off-service rotation. So my first half of the year has pretty much been like I did OBGYN. You have to get 10 plus deliveries on your own. So I did that. I did anesthesia where you intubate people. I did ultrasound, which is super important in the emergency department because it's not just for pregnancy, it's for a lot of other things. And it's a quick imaging modality with no radiation. It's fantastic. All EM doctors need to be very proficient in ultrasound. What else? I'm blanking. Neurology. We were on stroke team. So if people are having a stroke, we have to go, find those people, bring them to the CAT scan, do like whole stroke workup, all that stuff. So first year, you learn a lot of things from off service as well as in the emergency department. And emergency medicine is all encompassing. So like this is our textbook. It's one of a bunch of different textbooks. This is Tintinelli's. It's massive, but we have to read. We have chapters to read every week for because we have lectures every Thursday for 5 hours. We have lectures on whatever topics we were supposed to read about that week. And this is basically to keep us sharp for our emergency medicine boards, our board exams, which are at the end of third year. And in med school, you have 2 board exams, step 1 and step 2. And then typically people do step 3 their first year of residency, which I've already done my step 3. So I've done well on all the boards so far, and I just have emergency medicine left. Hope that answers your question.
Yeah, that did. Thank you.
Nadine or Nadine.
Hi, it's Nadine. I know it's spelled wrong.
Nadine. Sorry.
I know it's spelled wrong. I was just wondering, how has your general experience been in emergency medicine with like the pandemic? What have you noticed?
Yeah. So, the pandemic kind of canceled the rest of my rotations for 4th year, which kind of stunk. I had some pretty cool rotations planned. And I started residency in a pandemic. I was in the emergency room in July, which was the height of the pandemic down in Florida. You know how Florida was very delayed from everybody else because of nice weather or whatever. And, people started hanging out in big groups and it just was spreading like wildfire. So originally when I got to the hospital, they didn't want any residents seeing patients that they were suspecting having COVID. Right. And they were scared because they were like, all right, like we can't have residents exposed to this disease we know nothing about basically. And because there were residents dying from this disease actually, which is pretty crazy, which is due to viral load and all this other interesting stuff, but that's for another talk. So we fought back and said, no, this is our residency. Every day counts, every shift counts for our experience. And we need to get as much experience as possible because a lot of these people were crashing. A lot of these people were coming in cardiac arrest for assumed COVID because COVID can cause blood clots in the lungs. It can cause sudden cardiac death. It can cause a lot of different things. Obviously, decreased oxygenation to the lungs, all that stuff. COVID lung, COVID pneumonia. We see that constantly still. I just admitted someone for COVID pneumonia the other day, but so we fought for that and they were like, okay, fine. Emergency medicine residents are allowed to see COVID patients, no one else. So we were able to do that. And it was kind of crazy. We still do full gear and N95 and everything. But at the time we were doing like the hazmat masks and, we had the big plastic boxes that you put your hands in to intubate people. So there was a lot of crazy stuff that happened during those first couple months of my residency. I actually got COVID. I got hit pretty hard with COVID. That was the end of August, early September. It was terrible. Like I never had night sweats like that. I would sleep for like 1 hour at a time. It killed me for like 2 weeks. I had the cough, shortness of breath, chest tightness. I had everything. So when I got my first vaccine, like I had a pretty bad reaction because I had already had COVID basically. But that's a good reaction because that means your immune system's working, right? And then the second vaccine was like, oh, nothing. Okay. So that was kind of my experience with COVID. It's still going on, still around, despite what people may think. It's definitely still here. And a lot of the people down here who are getting that are like the obese people that didn't really believe in COVID. A lot of them saying, oh, COVID's not real, blah, blah, blah. And then they get it and then they end up in the ICU. And it's very ironic. It's actually kind of crazy, but we treat all our patients the same, no matter who they are. There's always internal biases, but you have to try to stop yourself from having an internal bias when you're in emergency medicine on the front lines.
Thank you.
Yeah. Alan Ood.
Hi again. I just had a quick question about your med school experience.
Sure.
And because you always hear, oh, this might affect your residency options, going to a Caribbean school. And so I'm a senior right now. I'm applying the cycle and it's a little stressful trying to make that type of decision. So I was just wondering what your experience was like.
Yeah, sure. So everybody has a different experience, right? That's what experience is. It's all subjective. Myself, I had an awesome experience at St. George's. Um, it's a lot more stressful because you have that much more pressure on you to do well. Um, in terms of my time on the island, I absolutely adore Grenada, and I want to go back there as much as I possibly can because it's a beautiful rainforest island. And when we finished exams, we would go party on the beach or go on a catamaran cruise, like all sorts of fun stuff. And I'm a musician, and so I play guitar and I sing, and so I would play gigs at the local brewery all the time, and I just had so much fun. Again, that doesn't mean we didn't work hard, because again, we had to do that much better than the US MD and DO students. And so they put a ton of emphasis on the board scores, step 1 and step 2. And now step 1 is actually pass fail. So I don't really know how that's going to affect Caribbean grads. Could go either way, I guess. Step 2 also is super important. And I crushed both of them. I did really well in step 1 and step 2. And that was huge for me. Another huge thing is networking, right? You have to be outgoing. You have to try to meet as many people as you want, can. Try to be as friendly as you can, as outgoing. So I'd say my third year, I got really involved in EMRA, which is the Emergency Medicine Residency Association. And that association are all the residents from emergency medicine residency programs throughout the country. So in addition to killing my boards and getting high honors on all my clinical rotations, I networked like crazy. And myself, as a St. George's grad, you only need like 12 interviews to have like a 97% chance of matching. And I got like 17 interview offers. I had some pretty big time academic offers too. Duke was one of them. Stony Brook, which is an amazing emergency medicine program, is one of them. Rutgers, Robert Wood Johnson. So it depends what you do with it. And I tell everybody who is questioning Caribbean Medical School, you are your own investment. It's a ton of money and it's a ton of time, right? Medical school in general is a ton of money and a ton of time. And it doesn't matter if you go to Harvard or you go to St. George's, medicine is taught the same. The research will definitely differ. Obviously, if you go to a big time academic center, you need to be into research. I'm not really that big into research. I did a couple papers and presentations, but that's not something that I'm passionate about. So going to St. George's was like, okay, I'll do like a couple research projects, got to just kill grades and boards. And that's the most important thing. But again, you are your own investment. It depends how hard you actually want to work. Because I tell everybody, you set yourself up for success or you set yourself up for failure. And that's up to you. Anybody who asks me, should I do it? I tell a lot of people, that's a huge decision to make. And I just took the leap of faith and I did it on my own. I don't have anybody in my family who's a doctor or in medicine for that regard, in that regard. So it was a huge decision on my part, but I met several EM docs that actually went there, and that kind of made me feel a lot better. And my undergrad GPA, I played baseball in undergrad, so I played a sport, so it took me away from the classroom a lot. So I think my undergrad GPA was like a 3.2. And I was like, all right, that's definitely not going to cut it for med school, even at Johns Hopkins, which is notorious for grade deflation, right? So I thought that would help. Did not. I got my master's at Drexel University in Philly. Didn't help enough. The program was too difficult. It was first year med school classes with the med students, and I got a 3.4, and they were like, "Oh, that's not high enough." But I was like, "Oh, they're first year med school classes. Like they were hard." So I did that, and then I scribed in the ER. And then during that time, I was like, "You know what? I'm not doing another cycle," because I did two. So I'm not doing it again. I'm putting all my eggs in one basket. And because of those 2 denies and those 2 gap years, I had that much more fire and willingness to just put all my effort into getting my MD and getting a match somewhere. And emergency medicine itself is extremely competitive nowadays. So I'm very, very thankful that I matched, but I also know how hard I worked and I know how much I set myself up for success. So in a short, run around of that question, it's up to you how hard you're willing to work. You are your own investment. Okay. So I know it's a really tough decision to make, but I'm proof, and there's a ton of students that are proof. They do really well in internal medicine matching, family medicine matching, and I know for sure they do very well in those. So you can be a doctor if you want to go Caribbean. Just realize it's going to be a more difficult road. But I feel like I have a chip on my shoulder compared to my MD and DO counterparts. Not to talk badly about them, but I feel like I had to work a little bit harder than them to get to where I'm at. So.
Do you know anybody who didn't match?
Oh yeah, of course. But again, these are individual cases. These are students that, I don't know, maybe they did poorly in one thing, or maybe they applied poorly. Maybe they applied to too competitive of a specialty. We had one person match into orthopedics this year, which we're not going for specialties like that or derm. Like that's not St. George's. That's not Caribbean. Like if that's what you want to do, then just keep trying to get into MD schools, and not even DOs. It's pretty tough to get in from a DO school too, because there's that stigma as well, but not nearly as bad as international medical grads.
But emergency is more attainable. You can match an emergency easier.
Well, it's not that it's easier. It's still extremely competitive, and it's just getting more and more competitive because people are looking at the lifestyle. You're never on call. You just do shift work. So a lot of the millennial docs like myself are like, okay, I don't need to like make my life completely about medicine.
Yeah.
So a lot of the MDs are going into these emergency medicine programs now, but I'm not saying that it's not impossible. I have many friends, like personal friends, that matched into EM from my school. And then if you don't match that one year, I have many friends that just matched this year. So they take a year off to do research, and then they come back a stronger applicant, and all of them match that I know that were in my class. So if they didn't match last year, they matched this year. And again, what's another year? I'm 29 right now, and it's like, people are like, wow, like it's taking you a long time to be a doctor. I'm like, well, I'd rather be a doctor at 29 than not a doctor.
Yeah.
So
yeah.
That's where I was at. That was my personal decision. So.
Yeah, it's just those exams. For me, it's not the grades. I do well in classes, and I just took my MCAT, and now I'm retaking my MCAT because it freaking sucks.
I was gonna say, so MCAT is also not indicative of the med student you will be. MCAT is garbage. I think MCAT is terrible. I did average on the MCAT. I was not a good test taker.
Yeah.
And then I learned how to study in my master's program, and I truly learned how to study in med school. And it's all about doing questions, as many questions as you can. It's not about reading chapters and highlighting and writing notes. It's not that. It's doing questions, getting things wrong, realizing why you got them wrong, and then just continuing to do questions. That's how you study. That's how you study for board exams. It seems really simple. It's not. It takes a long time to get that down, but I promise you, I was not a great test taker. And I proved to be a very good test taker after working my butt off in med school. So I promise you, like, don't get discouraged. It just comes with time, and it comes with practice and practice questions. So
yeah. Thank you so much.
Yeah, of course. Keep your head up. You'll do fine. All right. Anybody else got questions?
So I have a question for you.
Sure.
So for those of you who don't know, Dr. Reilly runs a podcast called Res Life. So I'm also shamelessly plugging here. So for any who want to check it out. So So I've been seeing this trend a lot of medical students and residents kind of posting their journey either through podcasts or YouTube videos or
Mhm.
platforms like Instagram. So I was just wondering what you think that impact will have for pre-meds and high school students to kind of have open access to these resources.
Yeah. So I think it's good and bad because you're going to get bad advice. You're going to get good advice. You're also going to get the medfluencers that just take pictures of themselves and write like one sentence that doesn't help you or give you advice at all. Which I shake my head at because I'm like, come on, guys, like, you've been where they're at. That's the whole point of doing this, right? The whole reason why I made my Instagram go towards um, pre-med advice, med student advice, like applying to residency advice, and just a general look into my life is because I feel like you should pay it forward and, each one teach one. Like I had no resources. I had no idea what I was doing when I was applying to med school. I had like my friends who were also pre-med who were doing stuff like, none of my family members are doctors. I didn't really know anybody who was a doctor. And the doctors that I know were old. So like they didn't really know the new process or anything. So I feel like with all of these good follows that you guys could do, they give awesome advice. One of my good friends who went to St. George's with me, her name's Caitlin McSurdy. She's an internal medicine resident at Temple. Her Instagram is prescription fitness MD. She gives like the best advice for IMGs and pre-meds, and it's like amazing. Her posts, her stories, all that stuff. And then mine's Doc Riles. If you guys want to give me a follow too, DocReilles. And then my other buddy who I do the podcast with, he's a neurosurgical resident at Mount Sinai in New York. His name's Dr. Schuper. He's a neurofitness MD. If you guys, I'll write them all down. Um, but there are so many good, we call it FOMED. It's like free online access medical education. There's so much of that on Twitter, on Instagram, on YouTube. Just don't fall into the trap of following people that are just doing it to boost their own egos or whatever. I like to have fun on my page too sometimes. Like I did like a day in the life yesterday, or a night in the life, which is pretty cool. I really enjoyed doing that. Just to like give people a look at my day, like when I get ready for a night shift or whatever, and then what happens on night shift. But a lot of my stuff is educational. Every once in a while, I'll throw like a video of me playing a song or something, but that's just because I love recording and writing music. So, and yeah, so those are really good ones to follow. And if you guys want to give the podcast a listen, we talk about a ton of different things. We talk about gap years for pre-med students, and just, getting ready to apply for medical school all the way through medical school and applying to residency and like certifying your match list and all this other stuff. Me and Dr. Schuper also started a new segment called So You Want to Be series. And we basically invite residents from other specialty onto the show, and we ask them questions about, how did you get involved in this specialty? What did you do to make sure you got there? Could you tell us, certain things about your specialty, blah, blah, blah. And he's done his, I've done mine. And then we just had a family medicine resident on as well. But we're trying to do more episodes and get more content out there, but it's on Apple Podcasts. If you guys want to check it out, it's called Res Life, and the Journey to Medicine, I believe is what it's called. I'll put it in here. But yeah, I mean, I think it's huge to have all the information that we have free for us online now. I know. I mean, in med school, in college, I loved like Khan Academy. If you guys have ever watched those videos, he's the best. He does such a good job. And I thought that was so cool that it was all free. I mean, obviously he's making a ton from YouTube, like commercials and stuff, but it was really cool. That was one of the like first online free like things. And I was like, wow, that's really nice. And that's kind of where things have gone. Another good one for med students in general is online med ed. It's all free videos online. Fantastic. But yeah, I'm a big fan. I'm a big fan of where, social media is going with doctors and, residents and different specialties. Again, you're going to get the ones that, just pose in front of the mirror and stuff like that, or, wear the fake scrubs, that kind of stuff. But, there's definitely a lot of very good ones out there for information on how to get to where we're at, because there is a lot of information that I wish I knew that I am now sharing with the world. So yeah, that's pretty much all I have to say about that.
All right, well, we can take one more question before we close out the session. So if any of you guys want to type out a question in the chat or unmute yourself, you're more than welcome to do so.
I have a question as to how you knew you wanted to do emergency medicine.
So my second gap year, I scribed in the emergency department in Trenton, New Jersey. I thought it was the coolest thing ever. And when I was in med school, I joined an emergency medicine interest group, a club, and that just opened it up a little bit more to me. And then third year, I got the best advice ever from a doc I used to scribe for. And for scribing, if you guys don't know what that is, it's somebody who basically writes all the doctor's notes, but you get to see all the things that the doctor does throughout his shift. So as a scribe, I saw emergency medicine. That was my first exposure. Then I went to emergency medicine club. I was one of our classes reps. And then third year, I had the best advice ever. He was like, just keep an open mind. Try to see yourself in every specialty that you are rotating on. And I did that. I tried to see myself as an internal medicine doctor, and then I tried to see myself as an OBGYN, then a surgeon, et cetera. And that made me enjoy those rotations that much more, because there are a lot of kids that just shut themselves out and said, I just want emergency medicine, or I just want surgery. I don't care about anything else. And then they miss out on those opportunities. And it's sad, because those are pretty cool opportunities that you may never get to do it again in your life. But my last rotation was emergency medicine, and that just like solidified everything. I was like, yes, this is 100% what I want to do, because it's all encompassing. It's all the specialties that I really liked. And yeah, so that's how I liked emergency medicine. Is it possible to major in both pharmacy and emergency medicine? You mean like from medical school? Because they're different degrees and they're different schools, right? There's a school of medicine, then there's school of pharmacy, I'm pretty sure, at different places. I mean, if you want to do that, we learn all the things that, or most of the things that pharmacy school or pharmacy students learn. We learn all of pharmacology, actually. We don't learn the nitty gritty of creating pharmaceutical chemicals, but we know every drug, we know every use for those drugs, we know every dosage, we know every side effect, we know every contraindication. Oh yeah, so medical pathway, you go from high school to college. You have to take certain classes that are required by medical schools. Then you apply either your junior or your senior year, depending on if you want to take a couple gap years in between to do other things and pad your resume a little bit more. And then you go to medical school. So high school, then 4 years of undergrad, plus or minus a couple of years for gap years, and then 4 years of medical school. And you are a MD or a DO. They're, in my opinion, they're literally the same thing, except DO, you have to learn osteopathic manipulative medicine, which is similar to chiropractic stuff and physical therapy. And then after that, you can, like, if you want to go administrative route, you can do like an MBA or whatever you want to do, to be honest. So.
Yeah, thank you for that. Also for Leah, I don't actually believe there is an emergency medicine major for undergrad.
Yeah, no, emergency medicine, that comes after med school. That's a residency. Residency is it's basically postgraduate. So you graduate from med school, then you go into residency. Depending on what specialty, it could be 3 years, 3 or 4 years for emergency medicine, 3 years for internal medicine, or you could be like a crazy person like my buddy, Dr. Schuper, and do like 7 or 8 years of neurosurgical residency. So, you're basically a resident for 8 years. Then you become an attending, which is an independent practitioner who's board certified in that specialty. That's when you actually start making real money. So I have another 3 years till I do that. So actually almost like 2.3 years left, which is kind of crazy. So.
Yeah, but if you are interested in pharmacy, since I have friends who've done that pathway,
yeah,
it's all you have to do is complete the prereqs and then you apply. So most people get it done in 2 years.
Yeah. And there's also other paths to medicine, guys. There's PA, which is super popular. There's NP programs. So you can go to nursing school and then get your NP. You're not going to be independent practitioners, but you're still in the medical field. You don't have the liability that doctors have, which is pretty cool, because, the United States is very litigious and they want to sue over everything. So emergency medicine is actually like the highest litigation, one of the highest. Like, we're constantly being sued. Even if we did everything right, we'll still probably get sued if the patient has a bad outcome. So, but that's why we have malpractice insurance, and the hospital pays for a lot of that too, and your group does too. So, but that's a different topic for another time.
Well, all right, guys. Thank you so much for attending, and thank you so much for the shadow session, Dr. Reilly. I know our members definitely learned a lot today.
Cool.
And yeah, I really loved your case study that you did. I always love it when people put pictures of the actual like imagery, because for me, that's like, I feel like that's a really important aspect, is being able to look at these and being like, okay, this is what we got.
Yeah, I'm a huge visual learner. That's why I told you guys, like, think about what this patient looks like in front of you. But yeah, no problem. I'm glad you guys enjoyed it, and best of luck to all you guys out there. If you have any questions, you could always DM me on my Instagram or whatnot. Okay, and take a listen to Res Life. Maybe you can learn a couple things too about the application process to medical school and beyond. Okay.